بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا محمد نبينا ومعلمنا وقدوتنا صلى الله عليه وسلم. اليوم نكتمل حلقات أو موضوعات الهايبوناتريميا. اليوم سيتم تقديم المحاضرة الثالثة. I am concentrated on the complication of overcorrection of hyponatremia, especially severe hyponatremia. And with osmotic demyelination syndrome, and for our pontine demyelinosis already, with the postmortem already after the patient dead, we are taking his brain and show this demyelination already that happened from overcorrection. This our iatrogenic complication from our mismanagement and overcorrection of hyponatremia. Osmotic demyelination syndrome, osmotic demyelination or central pontine myelinosis occurs due to rapid overcorrection of sodium when starting less than 120. This complication you should take care, you should put in your mind if you have any consult or any new patient with serum sodium less than 120 millimole. You should put in your mind, don't overcorrect this patient to avoid any risk, especially with patients with multiple risk factors for this disease, osmotic demyelination syndrome. You know, the most common risk factor for ODS or osmotic demyelination syndrome or central pontine myelinosis, we have the severe low sodium, especially if less than 110, and female in childbearing age, malnutrition patient, cachexia, alcoholic patient, hypokalemia, severe hypokalemia also associated with hyponatremia. This is the risk factor for osmotic demyelination syndrome. And this liver disease, patient with liver cirrhosis also is a risk factor. The risk factor for this disease, osmotic demyelination syndrome, the complication of overcorrection of hyponatremia. As we mentioned, the risk factor for osmotic demyelination syndrome, some factors related to plasma sodium and other related to the health. We discussed the health already: malnutrition, cirrhosis, hypokalemia, and alcoholism. Alcoholism, patient taking alcohol is all risk factor for ODS. Related to the serum plasma sodium, especially in hypovolemic patient. This is our second presentation of hyponatremia. Special patient with hypotonic, hypovolemic hyponatremia. This patient is already overcorrected by giving normal saline, and the patient go to severe polyuria and no follow-up. The patient will go the most risky patient for this disease, osmotic demyelination syndrome, because bad monitoring with urine output and his target or limit to correct his sodium. And the patient with rapid correction of chronic hyponatremia, very severe hyponatremia less than 105. Almost all cases report had plasma sodium less than 120. Any patient reported before in trials or case series already, this patient or most of them serum sodium less than 120. Very few cases report in patient with more than 120 or to 125 or more than 125. This is very rare to see this complication of our management of our hyponatremia. You know, this is our limitation for correction of hyponatremia. I discussed this slide before. If you see this correction sodium more than 10 millimole per liter in first day or first 24 hours, or more than 18 millimole per liter in first 48 hours, or more than 8 millimole per liter within 24 hours at any time, this patient in reading for this means the patient is high risk for ODS, osmotic demyelination syndrome. Why would overly rapid correction of hyponatremia occurs? While hyponatremia overcorrection occurs why? What is the causes of overcorrection of hyponatremia? And as we discussed before, also remove stimulus for ADH. Stimulus for ADH to retain the water already, this stimulus already removed or suppressed. And in cases with hypovolemic patient with gastroenteritis, diarrhea, vomiting, and the patient already volume depleted, and after you start for him normal saline, you restore already the stimulus, hypovolemic stimulus to ADH, and the ADH will be shut down, shut off, will be stopped, and this will lead to more polyuria and more water diuresis, and the patient will be overcorrected because he will retain sodium and will be more water diuresis. Water will be decreased and sodium will be retained in the body, and the patient will go to hypernatremia and will be overcorrected. Patient treated with Addison disease and with glucocorticoids, same mechanism, and patient to stop already medication cause syndrome, inappropriate antidiuretic hormone secretion, SIADA, and stop thiazide diuretic. Also, all this remove or suppress stimulus for ADH release. Give hypovolemic patient isotonic fluid, as we discussed this, increase the GFR and reduce the proximal reabsorption of filtrate, increase free water excretion. If the patient hypovolemic receive isotonic, this will lead to awake the GFR and increase the GFR and reduce the proximal reabsorption of the filtrate, lead to increase more free water excretion. And the second issue for giving vasopressor receptor antagonist, V1 receptor antagonist like tolvaptan. Tolvaptan, this will lead to a more water diuresis. It inhibit the aquaparine channels. Tolvaptan or conivaptan, they inhibit the aquaparine channels in the distal convoluted tubules and lead to inhibit water reabsorption and lead more water diuresis and maybe lead to overcorrection of our hyponatremia. Patient with trichogenic polydipsia. The patient also high risk for overcorrection. Patient with diabetes, central diabetes insipidus. No ADH already, this patient will develop also overcorrection of his hyponatremia. Patient with hyponatremia given 3% saline with too little monitoring. You are giving patient 3% saline as emergency in first presentation, and you don't follow up his urine output, urine osmolarity, and urine lights, and the patient already all the night, because most of these cases are problem happen at night, and all the night the patient polyuric and urine diluted, and the patient will go to overcorrection and the complication will be havoc because our bad follow-up for this patient. We have two adaptive response to hyponatremia, rapid response within hours. Within hours already this patient with normal brain here and normal osmolarity between intravascular and intracellular inside the brain cell. In acute hyponatremia, serum sodium will decrease, intravascular concentration or tonicity will decrease intravascular, and will be more hypotonic, and the same concentration still in the brain was high concentration will draw the fluid here and will withdraw the water and will lead to brain swelling and lead to brain herniation. This is a complication of acute hyponatremia, and this, with the rapid adaptation within hours, 2 days, as we mentioned before, you lead to a loss of sodium and the potassium and the chloride within 48 hours to be equal intravascular with intracellular inside the brain cells. Other slow adaptation will take long time to excrete other organic osmolytes like glutamine and tyrine and another amino acid to an extracellular compartment. Improper therapy and rapid correction of hypotonic during this period, and the brain here start to be hypotonic. And here, if you increase the sodium intravascular, what happened here, if a sodium concentration increase intravascular, will withdraw water from intracellular from inside the brain and lead to brain shrinking and lead to pontine myelinosis, and this osmotic demyelination syndrome will be having from our iatrogenic management for this patient. Take care, because I started by this hyponatremia to be aware how to manage hyponatremia. Otherwise, proper therapy will not lead, you will end by normal brain structure and concentration gradient between the osmolytes and the lights intracellular inside the brain and the intravascular space. This is a consequence of hyponatremia. We discussed this before already. We can miss this. Central pontine myelinosis is the pons already. Central CNS pontine from pons and myelinosis. This neuron damage and the destruction of myelin sheaths with acute rapid correction of hyponatremia from brain shrinking lead to central pontine myelinosis. Osmotic demyelination as a mechanism of shrinking of vascular endothelial cell and disruption of blood-brain barrier, influx of lymphocytes and the complement cytokines, inflammatory cascade already will be happening, macroglial activation and apoptosis, oligodendrocytes damage lead to all this mechanism, lead to demyelination. And I summarize here, this is a pathogenesis of osmotic demyelination, rapid increase of your serum sodium, lead to astrocyte shrink. With, if you correct your sodium rapidly, intravascular sodium will be high and brain will be hypotonic and the water will be withdrawn from the brain, from inside the brain to intravascular and lead to astrocyte shrink. We saw the astrocyte before in the first presentation. And apoptosis of astrocytes will be having loss of supportive astrocyte function and lead to endothelial cell function, opening of the blood-brain barrier, entering of immunoglobulin G and the complement into the brain, oligodendroglial cell dysfunction, loss of myelin, and lead to central pontine myelinosis at the end. Osmotic demyelination syndrome, how many days will you will observe your heterogenic complication on your patient? This occurs within 2 to 60 days, maybe within 7 days you will observe the side effect of your overcorrection of sodium, and not in second day or a third day. And sometimes it can occur rapidly within 2 days, within 48 hours. Symptoms include, you will observe your patient start to be dysphagia, inability to swallow, dysarthria, inability to speak, confusion, your patient already now confused, decreased level of consciousness, and you will see his behavior change. The patient will be irritable, agitated, loss of his concentration and confusion, paraplegia. Patient start before is mobile and he can mobile, after that no movement. The patient will be paralyzed. Obtundation, the patient will go stage of pre-coma and then seizure, he will maybe develop epilepsy. So I concentrate on hyponatremia to start my talk in nephrology, because to avoid this bad management or heterogenic complication by us when management patient with severe hyponatremia. And this some picture how to see central pontine myelinosis. You should ask for MRI brain, and you will see this bones here already with proptosis or myelinosis happen here on the central bones, and also the same here. This is osmotic demyelination syndrome, central pontine myelinosis, and this other one. And you will see also same here and this, and also you will see here central pontine myelinosis clear by MRI, and you will see multiple dots of pontine myelinosis, and same here with the normal one, this abnormal, and this here central pontine myelinosis, and with also white shadow, this is for central pontine myelinosis, and this also central pontine myelinosis, and this clear here. Strategies to prevent and manage overly rapid correction of our hyponatremia. As we mentioned before, we have proactive DDVB and reactive DDVB and risk DDVB. What means by proactive DDVB? When I suspect this is my patient, especially with patient with hypovolemic hyponatremia, when I suspect this patient will go to overcorrection, you should lock him from the start or keep DDVB beside him. Otherwise, if you see urine output increased hourly by 200 ml for 2 hours, or your serum sodium increase whatever within 24 hours at any time, rapidly 8 millimole or more, you should lock your patient by DDVB. Otherwise, to give forward to MIC as every 8 hours IV or subcutaneous. Reactive This means already your patient now overcorrected, or you see diluted urine osmolarity. So I ask you to check urine osmolarity and urine lysis and the serum sodium. If the urine diluted, urine osmolarity less than 100, less than 200, less than 150, with urine output, as I said before, and I will repeat it, this point, urine output more than 200 for 2 hours, or your sodium increase shot within 12 hours, around 8 or more than 6, and your patient is high risk, you should intervene now by the DVB urgent. Other risk, when there has been excessive rise of sodium beyond safe target. If your sodium reach more than your target, reach from your target, but your desired sodium should increase 6 and your sodium now increase 15 or 16 or 19, or you should look by the DVB and hypotonic fluid, D5 water or free water as you like. That's available with you. You can get D5 water if you don't have the DVB, with free water through NGT, through water intake if your patient is alert and conscious. You should risk your patient now. You should take care from your patient and you should intervene urgent as possible. When you decide or limit to raise your plasma sodium, what is the best time to decide to limit my sodium rising? If a patient is chronic or unsure, if your patient chronic, you are not sure this patient chronic or acute, just 8 millimole per 24 hours is your limit of rising your plasma sodium. If acute, including in hospital psychogenic polydipsia, just your limit 10 millimole if acute in hospital, or 8 millimole as otherwise. Definitely hyperacute, including exercise, marathon running, or post-surgery, TURB, uterine resection, or patient received recreational drugs, ecstasy. Probably okay to let rise to 130, but not advantage to doing so. The patient you can reach if hyperacute, as we know this patient at morning 135, and he just came maybe at 6 a.m. is 135, and maybe afternoon or 3 p.m. he reaches his sodium 120. At that time, it's safe to rise to 130, no problem. But better if you increase 10, for the first 24 hours, and after that you can return back to your normal sodium. This no problem. This is the best action to do with this patient. What should we do to avoid over rapid correction of hyponatremia? Be aware of possibility in all patients. This will be happening only you to take care and be alert with patient with plasma sodium less than 120 and less than 125 if risk factor, if patient with other risk factor for ODS, as we mentioned before, if the patient cirrhosis, cachexia, hypokalemia, alcoholic, like that. You should, to avoid this overcorrection or rapid correction, you should monitor regularly your serum sodium. Every 2 if the patient in ICU, or every 4 to 6 hours if the patient on ward. And your target to reach 130 point. This not within 1 day. This is your target to reach. This is our hope to return back to 130 by maximum daily around 10 to 8 millimole. Be especially vigilant in case where you should be hazard in cases with excess ADH effect reversed, especially in patients with hypovolemia. This is what I am concentrating on last presentation. Patient came by gastroenteritis, nausea, vomiting, diarrhea, and hypovolemia, and you give him normal saline to replete and rehydrate. And after that, you look ADH secretion, and the patient start to be polyuria. This patient is high risk for overcorrection. Consider a specific strategy to prevent or reverse over a rapid rise of serum sodium, as mentioned before. Proactive strategy. What it means by proactive? Proactive, as I mentioned before, this is proactive. DDVB means prophylactic DDVB. Upfront, you should keep this beside your patient, or you can start from the start if your patient high risk for overcorrection, especially patient hypovolemic or patient with high risk factor for osmotic demyelination syndrome. I can start, or patient like with severe hyponatremia and alcoholic, cirrhosis, malnutrition, hypokalemia. From the start, I can give hypertonic saline and DDVB in the other line to control my sodium rise. Otherwise, your patient maybe will go to polyuria and rapid correction and suddenly osmotic demyelination syndrome. And this not indicated for hypervolemic patient or patient with SIDH. DDVB contraindicated with psychogenic polydipsia is too risky. Why? DDVB will look urine, and the patient already polydipsia is drinking water, and you look urine, your patient will be high risk for osmotic demyelination syndrome. The proactive strategy, we can use this with patients with severe hyponatremia less than 120. This is reversible cause of ADH excess, especially in hypovolemia. Because if you correct the hypovolemia, as I mentioned before, you will look or shut off ADH secretion, and patient start to be polyuria, you will lose more diluted urine and water, and give a chance to sodium to be overcorrected. You should look this patient if you patient high risk, with high risk for osmotic demyelination syndrome. What I will do if I don't have DDVB, you should give D5 water or little patient to drink water. High risk of osmotic demyelination syndrome also, this was proactive strategy for DDVB, as I mentioned before. Perhaps most of the patient until diagnosis, if the patient is still diagnosed not clear and you still don't have data for your patient, you should look him and don't let him to overcorrect it from you. Reactive strategy is this patient, when you use this reactive DDVB means I will give DDVB according to, I saw now sodium increase from 110 increase to 125. This patient overcorrected, and I should lock him now. And when you see his urine osmolarity, as I mentioned for you, you now have serum sodium is overcorrected and urine osmolarity already diluted because the patient starts to be polyuria and more than 100 or 200 cc per hour. You should log this patient by DDVB, either 2 to 4 mic. I think 1 mic, nothing, will not do nothing. 2 to 4 mic, some doctors 6 mics, some reach to 8 mics every 8 hours. We observe this with Rabat et al. 2014 Clinical American Journal of Society of Nephrology. Around 20 patients in ICU with plasma sodium less than 120. DDVB given when diluted polyuria started. When the urine started to be diluted, started to give reactive DDVB for that. The urine volume here, parameters, and pre-DDVB and post-DDVB. Urine volume milli per hours 600. I told you if more than 100 or maximum 200 ml per hour, you should give DDVB. Here the urine about 650. After DDVB is now controlled to 94 ml per hour, and the urine osmolarity is diluted before. This means patient polyuria, lost more water and retaining sodium, and there's a risk for hyponatremia and overcorrection of hyponatremia. Urine osmolarity after DDVB reach here or 290 is increased already. We have response to our DDVB, and the rate of rise of sodium pre-DDVB 0.8 millimole per liter per hour. You have that to be safe in safe side in chronic hyponatremia, don't increase 0.5 millimole per liter per hour, and the post DDVB just minus 0.02 millimole per liter per hour. What if an overly rapid rate correction happened? Okay, now my patient, his serum sodium 110, and now his sodium now 118, increased by 18 millimole within 12 hours. How can I re-lower plasma sodium to risk strategy? This means to risk إنقاذ ما يمكن إنقاذه. Stop urinary loss of free water. How you can stop urinary loss? This patient now polyuria from overcorrection and shut off his ADH. You should give DDVB, the first line therapy, 4 mic every 8 hours. stop therapy directed at raising the sodium for at least 24 hours. If you are given hypertonic, normal saline, all this fluid should be stopped, or any medication, normal sodium chloride tab or other. Give free water. Empirical, you can give 3 ml per kg per hour, 200 cc per hour at least, per hour. And rules, either to give this hypotonic free water, either IV, if your patient can take oral, or NGT or oral. NGT oral, free water, and IV, you can give D5 water by this rate, 3 ml per kg per hour. If your patient overcorrect, or empirically 200 cc per hour. Goals, what is our goals? High risk of ODS, reduce rate in sodium to around 8 millimole per liter at 24 hours. Low risk, reduce rate of sodium 12 millimole per 24 hours. Please put in your mind, with a patient high risk of osmotic demyelination, keep this to maximum. If it's 6 is okay, if it's 5 is okay, if it's 8 is little bit okay, but if it's urine output with this 8 reach more than 200, you should look your patient, especially if high risk patient. And if you're low risk patient, maximum 10 ml per 24 hours. Monitoring, just check plasma sodium maybe every 2 hours. If you're a patient in ICU, I prefer to manage your severe hyponatremia in ICU other than the ward. At least we can follow up urine output and the plasma lights and urine osmolarity and the lights every 2 hours, whatever you need, until safe limit of correction reached. Expect plasma sodium to fall by 1 millimole per liter with this region. Your plasma sodium will decrease 1 millimole per liter per hour, and you will check your sodium on a regular basis. My home message today again. Chronic hyponatremia, please go slow. Don't be why you are hurried. If your patient is stable, no emergency, no seizure, no confusion, nothing, why you are hurried to correct hyponatremia? Please go slow. Don't be hurried. Go very slow. When your plasma sodium again less than 105, your patient with hypokalemia, malnourished, alcoholic patient, patient with liver cirrhosis, and patient with high catabolic cachexia patient. Our guidelines to treatment, again, I will repeat again, all patients should be on free water restriction, especially this patient with hypovolemia. You are given normal saline, please restrict water intake. Careful monitoring urine output, as I mentioned, every hour. If your patient can't collect the urine every hour, please put folic acid for life saving of your patient. And first sign of overcorrection, this urine output, if increase more than 100 to 100 ml per hour for 2 hours, this means your patient high risk for overcorrection. Rate of correction, especially at high risk patient, 6 millimole per 24 hours is a safe number. If low risk, just 8 is good, and the safe number within 24 hours or 18 millimole over 48 hours. Did AVB should be ready beside your patient if you will suppress his ADH release, especially patient with hypovolemia and you are giving fluid already. Patient otherwise will go to more, even more hyponatremic if you will not restrict his free water intake. How to avoid overcorrection of hyponatremia? Monitor as again serum sodium. I need serum sodium, urine lights, and urine osmolarity and urine output. Put this to know because this is a closed box. I need to know what is the patient excrete, and it also what is inside sodium and what is his excrete and what is the urine amount, urine osmolarity, diluted or no, still concentrated or diluted, and the urine output hourly. The best strategy to keep your patient away from iatrogenic complication of ODS from our management. The AVB to be ready, consider as a proactive administration if your patient high risk for ODS. The AVB to be ready and consider as the proactive. Proactive, you should give, don't wait to be overcorrected. You can start that. I have one consultant here already given DDVB with hypertonic saline, one running on one line and another one on another line, both together to avoid overcorrection, especially his patient malnutrition, cirrhotic patient, and hypokalemia and alcoholism, and severe hyponatremia patient. In almost the case, avoid correction hyponatremia faster than 8 to 10 millimole maximum per day. If high risk for osmotic demyelination, 6 millimole per day is okay. Continue slow rate of correction until serum sodium reach 130. With definite acute hyponatremia, the patient, I know this patient, as I said before, patient 6 a.m. is sodium 135, 140, and he's dropped to 120. It's safe to correct him to 130, no problem, in the first 24 hours. But it's preferred to just correct 10 millimole per liter per day until reach your target. Please, again, don't exceed 8 millimole per day. High-risk patient don't exceed 4 to 6 millimole per liter per day. Don't be hurry. If your patient is asymptomatic, why you are hurry? And this our target from this presentation to avoid this complication, osmotic demyelination syndrome, and your patient will end up by being handicapped and paraplegic, and with our bad management for our patient and bad monitoring and the bad follow-up. With our reference, if you like to read more for more details for more our presentation today. And I hope our presentation today and my message clear and reach to each one on our field to protect our patient and to keep our patient life safe. ونسالكم الدعاء بالتوفيق والسداد، ولا تنسونا من صالح دعائكم بالصحة والستر والعافية والبركة، ولا تنسوا الصلاة على السلام على حبيبنا محمد صلى الله عليه وسلم، معلمنا وقدوتنا ونبينا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته، ونلقاكم في فيديو قادم قريبا بإذن الله. وما زلنا في الهايبوناتريميا، سنستمر فيها إلى أن نغطي كل النقاط الحرجة في الهايبوناتريميا وتغطية جميع أجزاء الهايبوناتريميا وجميع حالات الهايبوناتريميا، وكيفية التعامل مع الهايبوناتريميا في مرضى الغسيل الكلوي ومرضى CRRT بالعناية المركزة. يتم إنهاء الهايبوناتريميا بطريقة اكلينيكيه، وكيفية التعامل مع المريض بطريقة آمنة updated. وفقط نسألكم الدعاء بالتوفيق والسداد، ونراكم على خير بإذن الله، ونلقاكم في فيديو قريب إن شاء الله. السلام عليكم ورحمة الله وبركاته.